So now we are coming to the most important aspect in this chapter. As a surgeon, we have to know the various types of surgical options available now. See, there are many updates in the surgical treatment options. So I want you to be thorough with the surgical treatment options. So number one, the first surgery mentioned is skin and nipple sparing mastectomy. See, very interesting. What is this skin and nipple sparing mastectomy? So this is the breast, this is a nipple, this is a breast tissue. If there is a cancer like this, usually I will do a wide local excision including the skin of the breast or including the areola sometimes. But if there is a cancer very far away from the nipple areolar area, it is very far away like this, I can only excise this like this. It is called as nipple and skin sparing mastectomy. For this, the criteria is the tumor should be more than 1 centimeter from the skin and more than 2 centimeter away from the nipple. Then only I can give a wide local excision, because I have to give 1 centimeter margin. So to give an 1 centimeter margin, I need the tumor to be 1 centimeter away from the skin and 2 centimeter away from the nipple. It is usually done for ductal cancer in situ cases. Please remember. And the breast may be reconstructed using autologous flap or something, so that we can easily manage the patient with a good cosmetic look. So since I have preserved the nipple and areola, if I keep a silicone implant underneath, it looks as if like an original breast. That is advantage of skin and nipple sparing mastectomy. New update in Bailey and Law. This is a new update. Okay, new update in 28th edition Bailey. The old treatment, which was known as breast conservative surgery, is very well updated in Bailey and Law. What is breast conservative surgery? See, this is a tumor. This is a tumor. So the tumor is now here. I have to resect the tumor with a 1 centimeter margin like this. I will include the nipple skin also sometimes. I have to open it. Depending upon the location, I sometimes need to open and remove the skin also if it is very close to the skin. Whatever it is, if this is a tumor, I should give 1 centimeter margin all along. 1 centimeter margin is given all around the tumor. I have to give a 1 centimeter margin and take it out. After taking out the tumor, I should put a long thread laterally. Laterally tie a long silk and superiorly tie a short silk. So short silk superior, S for S, long silk laterally, and send this specimen for frozen section or for regular histopathological examination. We can even send it for frozen section. But usually nowadays they are sending for histopathological examination, and the pathologist will be seeing all the margins for any positivity. So anywhere if it is positive, they will tell the surgeon, sir, your superior margin is positive. Then what I will do? I will go back and I will cut the superior margin side more. So I will cut the superior margin side more. That is advantage of tying a long lateral and short superior thread. The pathologist will tell me which margin is positive. So this surgery of giving 1 centimeter margin is known as breast conservative surgery. So you can see an image of a breast conservative surgery shown here. You can see we have put an incision, we have removed the tumor, and into that we have kept a suction drain like this. So in the operative area, and also the axillary dissection is done. If there is an axillary dissection done, you will keep a suction drain even into the axillary dissection. So this is a picture showing you breast conservative surgery. So here I want you to understand what is breast conservative surgery. So as you are discussing about this surgery, you have to understand breast conservative therapy is the original name of this, which is including 4 steps. Please remember, breast conservative surgery is a surgery which is made up of 4 steps. What are the steps? Number 1, breast conservative surgery. Like as I discussed, 1 centimeter margin, wide local excision. That is number 1. So wide local excision of 1 centimeter margin is done, number 1. After removing the tumor, I should give radiotherapy to the remaining breast. Please don't forget, that is the most important thing. Radiotherapy to remaining breast. Remaining full breast will be given radiotherapy conventionally. So after doing a wide local excision, give radiotherapy to the remaining breast. Then what about the axilla? I have to deal the axilla also. After treating the tumor, I have to treat the axilla also. If N0 case, I should do sentinel node biopsy. If N is positive, I should do axillary dissection. You will understand those procedures in the subsequent discussion. So please remember, N0 means sentinel node biopsy. N plus means axillary dissection should be done. And what is the fourth step? Follow-up. The most important thing is follow-up. Very important, please don't forget, breast conservative surgery is not surgery alone. It includes breast conservative surgery plus radiotherapy to the remaining breast plus dealing the axilla, and number 4, follow-up of the patient, regular follow-up of the patient. So now, what are the contraindications of breast conservative surgery? Please don't forget. Very interesting concept, and this is a repeat MCQ. When 2 times wide local excision, 2 times wide local excision margin is positive, I cannot do breast conservative surgery. 2 times I can do wide local excision. If 2 times positive, abandon the procedure. Multicentric tumors and multifocal tumors you should not do, because I cannot do a wide local excision. So diffuse microcalcification, we call it as diffuse microcalcification, we cannot do, because I need to do a wide local excision without any residual tumor. Therefore, wide local excision cannot be done in multicentric, multifocal, diffuse microcalcification tumors, and the breast is small and the tumor is big. So this we call it as abnormal tumor breast ratio. For example, the breast size is 5 cm, tumor is 4 cm or 3 cm. If I give a wide local excision, it cosmetically looks ugly. So cosmetically unacceptable, because it is a cosmetic surgery. No, cosmetically if it is unacceptable, no use of doing that. Please don't forget. And skin involvement present or chest wall involvement present. That means what? T4 cases you should not do. When there is a skin involvement seen or chest wall involvement seen, you cannot do. In otherwise, breast conservative surgery can be done only for early breast cancer. Only for early breast cancer, this concept, breast conservative surgery concept, is only for early breast cancer, not for locally advanced breast cancers. So skin involvement seen, chest wall involvement seen, I cannot do this operation. Okay, so please don't forget, more than 2 times wide local excision positive, multicentric, multifocal, diffuse microcalcification, tumor breast ratio is unacceptable, skin involvement is there, chest wall involvement is there, and whenever the radiotherapy could not be given, radiotherapy contraindicated, I cannot do breast conservative surgery. What is radiotherapy contraindicated? Number 1, pregnancy in first and second trimester. I cannot do in pregnancy first and second trimester. I cannot do. Number 2, in pregnancy first and second trimester. Number 2, in patients who are already having collagen vascular disease, because in collagen vascular disease, radiotherapy is contraindicated. And prior history of radiotherapy. If already some radiotherapy is given, that is another contraindication. So prior history of radiotherapy, collagen vascular disease, pregnancy in first and second trimester, all these are contraindications. And patients having ankylosing spondylitis, because the patient cannot lie on the bed for radiotherapy. The radiotherapy plates cannot be properly placed. That is ankylosing spondylitis. Large pendulous breast, because in a large pendulous breast, we cannot do a breast conservative surgery and give radiotherapy to the remaining breast, because the breast will be hanging to the abdomen. If I give radiotherapy, that can attack the abdominal organs also. So large pendulous breast is another contraindication. And when the patient is unable to come for follow-up, like psychiatry patients, will come under this criteria. Psychiatry patients and low socioeconomic status. So low socioeconomic status and psychiatric patients, we have to go for the definitive MRM only. So these are the places where breast conservative surgery is contraindicated. Usual question, this is a usual question. Therefore, I am telling you one important MCQ clue. Breast conservative surgery is contraindicated in the following, except will be the question. Except what? Except number 1, centrally located tumor. When the tumor is in the central, it is not a contraindication. Centrally located tumor, number 1. Number 2, when the tumor is in the center, is not a contraindication. And family history is not a contraindication. And number 3, please understand, lymph node positivity is not a contraindication. This will be the 3 choices in the exam. So please remember what are the points that will be asked in the exam is, centrally located tumor is not a contraindication, family history is not a contraindication, lymph node positivity is not a contraindication. So now after this wide local excision, very important update from 28th edition, up to 20% of the breast volume can be achieved by excision of the tumor. See, after 20% of the breast volume can be mobilized. Up to 20% if you have removed, nothing to worry, we can do straightforward reconstruction. But if it is more than 20% or an unfavorable breast tumor ratio, it needs oncoplastic procedures. Though it is a little high-fi for your exam, you have to know this because it is there in Bayesian law. Oncoplastic procedure is nothing but the breast tissue is not sufficient. So I am going to do something to make it look like a breast. That is known as oncoplastic procedure. This is volume displacement or volume replacement using a distant flap. So volume displacement is a dual plane mobilization. So the breast tissue is mobilized and bring it to the plane such that I can make it closed. So for example, this is a gap in the breast. This is a gap in the breast. I can mobilize these tissues and I can make it bring there and I close. This is known as volume displacement. Using the breast tissue at the level of pectoralis, we have to mobilize. Whereas volume replacement, it needs complex procedure because it is a very huge defect. So very huge defect, like more than 20% patients with a huge volume defect, I need to bring a muscle flap and keep it inside. That is what called as volume replacement. So volume displacement, volume replacement are the two types of oncoplastic procedures I want you to remember. What are the two types of oncoplastic procedures done? Please don't forget this. So this is about the basics and new updates from Bayesian law related to breast conservative surgery and oncoplastic procedures after breast conservative. Up to 20%, no need of reconstruction, but more than 20% needs volume displacement or volume replacement. Don't forget these concepts, okay? So now we are going to see one of the important concepts related to cancer breast, that is sentinel node biopsy. What do you mean by sentinel node? Please understand what is meant by sentinel node. Sentinel node is the first node involved from any cancer. Please understand this concept. Sentinel node means that is the first node involved from any cancer. This concept actually was very famous for cancer penis, for melanoma. Many cancers, it was once upon a time very famous. But now, since they found out there is no proper sentinel node travel in many of the other cancers, it is not a protocol in many other cancers like melanoma, cancer penis, and all, they removed that concept. So as of now, the gold standard cancer where it is used is only for cancer breast. So don't forget, sentinel node means the first node involved from a cancer. So this is done for N0 cases. N0 cases means what? When you can't palpate a node, when you cannot palpate a node on examination, when there is no node palpable, this is done. Sentinel node biopsy is done only for patients for whom you are not able to palpate a node from the cancer. So now, when there is an NO node, what I am going to do, step-by-step protocol, when there is no node, I am going to use some substances like blue dye or something I am going to discuss later. I am going to inject some substances which will identify the first node. So the first node, known as sentinel node, is taken for frozen section biopsy. So the frozen section biopsy from an axillary node, usually the first node in breast is called as Giuliano node. That is known as sentinel node. Giuliano node is a sentinel node in breast. That is the first node involved, and it is usually an anterior axillary group of node. It is usually an anterior axillary node. So I am going to take all the nodes which are getting the stain or the radioactivity and send it for frozen section. If it becomes negative, what will I do? If there is no microscopic metastasis in any of the nodes, I will only give radiotherapy to axilla. That's all. Nothing else needed. If it is negative, radiotherapy is enough for the axilla. If the frozen section becomes positive, what will I do for a positive frozen section biopsy? If it becomes positive, I have to go for a complete axillary dissection. So the dissection done for cancer is known as axillary dissection procedure. I have to go for an axillary dissection procedure. So please don't forget, radiotherapy to the axilla if it is negative, and if it is positive, I need a axillary radio dissection, complete dissection for positive cases. Negative cases, radiotherapy to the axilla. See, axillary dissection is a morbid procedure which we are going to understand later. By doing such a morbid procedure, we can cause many damage. So We can avoid such a unwanted axillary dissection when there is no node seen. That is the concept of frozen section biopsy. So axillary dissection is done for those cases. Now, what is the indication of sentinel node biopsy? Please understand, sentinel node biopsy is done only for N0 cases. N0 means no palpable axillary node. So indicated only for N0 cases, and it is indicated only for early breast cancer. It is only done for early breast cancer patients. Who will you do this sentinel node biopsy? Means for no palpable nodes in an early breast cancer. In a locally advanced breast cancer, what are the contraindications? Please remember, it's contraindicated in locally advanced breast cancer. I hope you know what is locally advanced breast cancer is. The cancer which is involving skin and chest wall. Even if they don't have palpable nodes, we have to do axillary dissection in T4 and inflammatory breast cancer patients. And we cannot do the sentinel node biopsy for a burns case. The breast is having a burns or previous surgery is done on the burns. Means what? When there are previous surgery or previous breast scarring, those cases, the sentinel node pathway will be disturbed. That will be going in a different pathway. So sentinel node will not be accurate in those cases. So those cases we will not do. So because the sentinel node is disturbed, sentinel pathway is disturbed in these cases. Okay, radiotherapy is already given means I cannot now again radiotherapy to the axilla. So radiotherapy previously done is another contraindication. So wherever radiotherapy cannot be given also is a contraindication. Example, pregnancy first and second trimester is a contraindication. Pregnancy first and second trimester is a contraindication for sentinel node biopsy. In third trimester, I can do. In third trimester, you can do sentinel node biopsy because if it is negative, after the birth of the baby, I can give axillary radiotherapy. So can be done. So sentinel node biopsy can be done in third trimester, but not done in first and second trimester is another contraindication of sentinel node biopsy. So please understand how it is done. So sentinel node biopsy is done by three common methods. In India, we are still using blue dye known as methylene blue. So we have to inject that blue dye. So blue dye is injected peritumorally around the tumor. Just injected around the tumor. Peritumorally area, you inject blue dye and you can see the picture showing you the blue color nodes in the axilla. Take those nodes and send it for frozen section biopsy. So another method which is commonly done in Western countries is they inject radio-labeled colloid. So radio-labeled substances. We can inject radio-labeled substance. Where do they inject? They inject in the periareolar area. Not in the tumor area. They inject it around the areola. Around the areola they inject it and they will use a special camera known as gamma camera. That is the image shown here in the picture. You can see a picture of gamma camera is used in the axilla. That will show you the highest radioactive nodes. So whichever nodes are radioactive, we will take them and send for sentinel node biopsy. That is done with the help of radio-labeled substance like albumin, sulfur colloid or antimony. All these substances can be used for these procedures. Radio-labeled albumin, sulfur, antimony are all used in this. And recent update from 28th edition is now we are using a special dye known as indocyanine green dye. If radioisotopes are not available, we will use a indocyanine green dye and we have special lights which will show you the sentinel node. So please remember, a new update is dye is also used for sentinel node biopsy. Please don't forget this. How to confirm whether the node is positive? It is either by doing a frozen section analysis or by doing touch imprint cytology or by looking for mammoglobulin and CK19. Okay, CK19 and mammoglobulin are positive from the tissue. So CK19 and mammoglobulin, touch imprint cytology, frozen section. But in India, still we are doing this frozen section commonly. So frozen section is a very important role, having an important role in sentinel node biopsy. So please don't forget the concept behind sentinel node biopsy. Sentinel node biopsy is a separate short note question for final year students. For a PG aspirants, this is a very, very important high yield topic. So be thorough with this topic. Okay, sentinel node biopsy. So now we are going to the conventional procedure for cancer breast, that is MRM, Modified Radical Mastectomy. We are going to discuss about MRM. So please understand what is MRM. I am going to explain you the procedure of MRM in an illustrated way. See, this is a cancer here. This is a cancer here. I am going to do an incision like this. What is the name of this incision? The name of the incision is called as Stewart's incision. Stewart's elliptical incision, which includes nipple and areola. Includes nipple plus areola is included in this incision. Please don't forget this. So the incision I am making is including nipple and areola also. So after putting this incision, I have to raise the flap. Flaps are raised above and below. So above it is raised up to the clavicle. Below it is raised down up to the inframammary area. So below up to the inframammary area, above up to the clavicle, I have to raise the flaps. Now completely remove the breast tissue. That is the most important. What is I am going to remove? I am going to remove nipple, areola, breast tissue, everything I am going to remove. Nipple, areola, complete breast tissue I am going to remove. So during the process of removal, I will include the tumor also. Tumor is included in the breast tissue. And I should remove the pectoralis fascia, not the muscle. Please remember, I should not remove the muscle, I should remove the pectoralis fascia. And along with this, in an MRM, it removes level 1, 2, 3 axillary nodes are removed. Level 1, 2, 3 axillary nodes are also removed in this dissection. So level 1, 2, 3 axillary nodes are also removed in an MRM. So nipple, areola, breast tissue, tumor, pectoralis fascia. We have removed level 1, 2, 3 axillary nodes also in this process. In the process of MRM, I have removed level 1, 2, 3 axillary nodes also. So please remember, what is preserved in MRM? So what is preserved in MRM is A, B, C, D, M. Axillary vessels, axillary artery and vein, okay, Bell's nerve, cephalic vein, thoracodorsal nerve, that is a very important thoracodorsal nerve. And the muscle, you all know very well, pectoralis major muscle. So what are all the structures preserved in MRM are axillary vessels, Bell's nerve, cephalic vein, thoracodorsal nerve and pectoralis major are the structures I should carefully preserve while doing this operation. What is the structure? Preserved are these structures. So now coming to the axillary dissection procedure. What is this axillary dissection procedure? I hope already you understood the axillary level of nodes in the previous dissection discussion. So this is a pectoralis minor muscle. Please remember, this is pectoralis minor muscle. The nodes lateral to the pectoralis minor are coming under level 1 nodes. The nodes at the level of pectoralis minor is level 2 nodes. Medial to the pectoralis minor is level 3 nodes. So we have to remove all these 3 levels of nodes, that is known as axillary dissection. In the method of axillary dissection, there are 3 methods. One is Patty. When removing axillary dissection by Patty's method, I will remove level 1, level 2, level 3 nodes by removing the pectoralis minor. Pectoralis minor is removed in Patty's type of axillary dissection. Hutchin class type of axillary dissection. So this video of axillary dissection I have updated at the end as video question. Okay, so where videos I have all this topic videos I have updated or uploaded at the end of the discussion. You can go through that video to understand this procedure. So Patty's by removing pectoralis minor, Hutchin class by retracting pectoralis minor. So we have to retract the pectoralis minor for Hutchin class, and Scanlon I will do cut the pectoralis minor and resuture it. That is known as Scanlon. In Patty's I cut and remove it out. In Scanlon I cut and after surgery I will remove reconstruct it. In Hutchin class I will do retraction. The commonly followed method is Hutchin class. But the problem in Hutchin class is difficult to remove level 3 nodes. Difficult to remove level 3 nodes in an Hutchin class. But up to level 1, level 2 you can remove in Hutchin class, but very difficult to remove the level 3 nodes. We have to retract so much and we have to go inside and remove it. But many times level 3 nodes are not being removed in Hutchin class. So Hutchin class is commonly followed method. So most commonly done method of axillary dissection is Hutchin class in practice, and minimum number of nodes that should be removed is how much? minimum of 10 nodes should be removed. Please don't forget. The minimum number of nodes I should have removed in this procedure is 10 number of nodes should be removed in this procedure. Okay, so this is a classical topic, MRM and axillary dissection procedure. This is a conventional procedure we do in practice. During this MRM and axillary dissection, tell me what is the most common complication. So the most common complication is seroma formation. Seroma formation is the most common complication of MRM. And the most common nerve injured is, what is the most common nerve injured? See, please don't get confused in the exam. It is not Bell's nerve. It is intercostobrachial nerve. Intercostobrachial nerve is the most common nerve injured. It is a cutaneous nerve. Okay, it is nothing to worry. It is a cutaneous nerve that is having a paresthesia in the chest wall. After cutting this nerve, the patients may feel some paresthesia in the operative area. That is the most common nerve injured. Yes, as you are telling, Bell's nerve can be injured. Okay, Bell's nerve can be injured. Thoracodorsal nerve can be injured. All those are correct. Thoracodorsal nerve can be injured and Bell's nerve can be injured. All those are correct. But Bell's nerve injury will result in winging of scapula. Winging of scapula. Thoracodorsal injury, what will result? It results in shoulder movements are affected. Very rarely, pectoral nerves are very rarely injured. Medial and lateral pectoral nerves are very rarely injured, but not common. Their chest wall movements are little affected. So medial and lateral pectoral nerve injury is very rare injury. Compared to Bell's nerve and thoracodorsal, medial and lateral pectoral nerve injury is very rare. So suction drain related points I want you to know. What will happen? See, I told you the most common complication is collection of fluid in the axilla. So now we have kept a suction drain to suck the fluid out. Suction drain is kept. So Romovac type of suction drain is kept. That suction drain will be usually removed when the fluid coming is less than 20 to 30 ml. Removed at 20 ml or less is coming. When the fluid coming out from the drain is usually 20 ml or less, we can remove it. So there is nothing to worry when the content of fluid coming is less than 20 ml. Usually we have 100 ml, 150 ml, 200 ml for the first few days. Usually after 5th day, 6th day, the seroma will stop. But by chance, if you have removed accidental removal of suction drain, what will you do? Because there is going to be seroma get collected in the 2nd, 3rd day. So such cases, I should do repeated aspiration. Please remember, I should do repeated aspiration and I should make a tight strapping of the elastic grip bandage. Tight strapping done with the elasto grip bandage. After daily 2 days once, we have to remove that fluid and we have to put a tight strapping until it becomes less. So tight strapping is done for those patients. Repeated aspiration and tight strapping is done for those patients who are having accidental removal of suction drain. Please remember, accidental removal of suction drain. What should I do is tight strapping is done and we have to do repeated aspiration. So now it's a time you have to know an extra edge in axillary dissection procedure. So what is the extra edge? I want you to know about the boundaries of axillary dissection. Very important question for your exam. So you should know about the boundaries of axillary dissection. So I am now drawing the boundaries of axillary dissection, which is an essential topic for NEET PG. Boundaries of axillary dissection. This is a classical repeat question because very commonly asked in AIIMS and other exams. So please remember, this is axillary vein. Superiorly, you have axillary vein and axillary artery. Axillary vein and axillary artery. This is axillary artery. So superiorly, axillary vein and axillary artery on the superior boundary. So medial boundary is Bell's nerve. Please don't forget, this is Bell's nerve. I have shown this in the video session. Please go through that. So axillary vessels superiorly, Bell's nerve medially. Laterally, what is present? Can you tell me? Laterally, we have the artery coming from axillary artery and axillary vein known as thoracodorsal artery, thoracodorsal vein. Along with that, we have a nerve. So thoracodorsal artery, thoracodorsal vein, thoracodorsal nerve. This together is called as thoracodorsal pedicle. This is called as thoracodorsal pedicle. So combined thoracodorsal artery, thoracodorsal vein, thoracodorsal nerve is the lateral boundary, and inferiorly we have some veins coming from here known as angular veins. So what are the boundaries of axillary dissection? Axillary dissection is bounded by axillary vessels above. Axillary vessels are the boundaries above, medially by Bell's nerve, laterally by thoracodorsal pedicle, inferiorly by angular vein. So this is the boundaries of axillary dissection. Please don't forget this boundary. So in this boundary only, you should not forget this is the pectoralis minor muscle seen here like this. This is the pectoralis minor here, which will be retracted in Achin class, which will be cut and removed and patties cut and resutured after procedure and scanlon. So these are level 1 nodes, this is level 2 nodes, this is level 3 nodes. All these nodes to be removed, and the total number of nodes you must have in the specimen is minimum of 10 nodes. Then only we can say you have done a good axillary dissection. Otherwise, you have not done a good axillary dissection. Please remember this concepts behind axillary dissection concept. Okay, axillary dissection concept is very important, extra edge for final years and for PG aspirants. So now I have completely removed the tumor. The major problem after removing the breast is patients will get depressed for the removal of breast. So now comes the topic of reconstruction. How will I do after MRM? So how will you reconstruct after MRM is a very important topic for exams. So please remember the two methods of reconstruction are: number 1, using autologous tissues. So using tissues in your own body. Number 2, by using silicone implants. So silicone implant and autologous tissues are the two methods of reconstruction of the breast. So reconstruction of the breast using autologous tissues, I'll tell you, this is the patient. Please understand this picture. See, this is a patient now. The left breast is present, right breast is removed. Okay, right breast is removed. And this is the abdomen. So olden days, we used to do this flap commonly. So what is this muscle? This is called as rectus abdominis muscle. TRAM flap. So olden days, we used a TRAM flap known as transverse rectus abdominis muscle flap. Transverse rectus abdominis muscle flap was used once upon a time. So this muscle flap is a pedicle artery based on this artery, based on pedicle flap based on superior epigastric artery. It is a pedicle flap which is supplying a superior epigastric artery is supplying this muscle. So what we will do? We cut the muscle here, take the muscle and keep it here. So there is no need of any microvascular anastomosis. Just you transfer the abdominal muscle to this side. That's all. No microvascular anastomosis needed. It's the easiest operation, but the problem is what? Why this procedure is no more done? Because of the increased risk of incisional hernia in the abdomen. Increased risk of incisional hernias which happened in the abdomen. Therefore, it is not done now. So now we are doing another flap. Very commonly done flap is using the fat in this lower abdomen. This is a fat in the lower abdomen. All of us will have a little amount of fat in the lower abdomen. That fat can be transferred here. That is known as, what is the name of this flap? This is known as DIEP flap. So DIEP flap is deep inferior epigastric artery, based perforator flap. Please remember, it is a free flap based on inferior epigastric artery. Means what? I should do a microvascular anastomosis. I have to take that skin subcutaneous tissue from below and I have to keep it here and I have to do microvascular anastomosis with the arteries somewhere nearby. That is known as DIEP flap. It is a microvascular flap. It is commonly done flap now. It is the most commonly done flap now is DIEP flap, and 28th edition Bailey has updated so many new flaps like gluteal muscle flap, Gluteal muscle can be brought and kept here. The gluteus muscle that can be kept here. So based on superior and inferior gluteal artery, that is mentioned in Bailey. Latissimus dorsi flap. Many flaps are mentioned in New Edition Bailey. But what is MCQ flap from Sabiston is DIEP flap. So don't forget the olden days flap of TRAM flap is no more done in practice. In TRAM flap is not done by the plastic surgeons in practice. Most of them are doing only DIEP flap because it is better cosmetic as the flap is in the lower abdomen and you can transfer the fat and subcutaneous tissues here without any risk of incisional hernia in the lower abdomen. Okay, don't forget this point. Silicone implant is indicated for bilateral breast reconstruction. If a patient wants to do reconstruction of both breasts, bilateral breast reconstruction, in such cases, the fat alone, DIEP alone is not sufficient. Or patient wants augmentation. Patient tells her, I want augmentation also. Augmentation requested by the patient. So when there is a bilateral breast reconstruction needed or the patient wants augmentation of the breast, in such cases, I will go for a silicone implant procedure. That is the procedure where I will do silicone implant procedure. So please don't forget this point. Silicone is contraindicated in some patients. Contraindication of silicone is number 1, allergy to silicone, and number 2, if you are going to give radiotherapy, you cannot use silicone. If radiotherapy cannot be given after silicone, because the silicone will get destroyed on radiotherapy. After radiotherapy cannot be given after silicone implant. Therefore, if you want to give radiotherapy, you cannot use silicone. So these are the contraindicated in patients who need radiotherapy and is contraindicated in silicone allergy patients. So reconstruction is an essential topic. Please remember, reconstruction olden days commonly done by a TRAM flap, which is a pedicle flap. So recently we are doing with the DIEP flap, which is a free flap. So you will understand what is pedicle and free flap in plastic surgery. Please go through here now. Pedicle flap is based on superior epigastric artery. Free flap is based on inferior epigastric